And now it's my pleasure to introduce the oral abstract presentations, fourth session, viral hepatitis infections, and it is concerned with hepatitis C. And our first speaker will be from the United Kingdom, Dr. Alexander Stockdale, presenting on seroprevalence and molecular epidemiology of hepatitis C in Malawi, a cross-sectional community census-based serological survey.
Hi, my name is Alex Stockdale. I'm a lecturer in infectious diseases, and I was working in Malawi for 3 years in the Malawi Liverpool Wellcome Trust, and as a consultant physician at the Queen Elizabeth Central Hospital in Blantyre. I'm going to be sharing with you the results today of our cross-sectional community census-based serologic survey of a township in Blantyre in Durande. So in terms of an epidemiological assessment of hepatitis C prevalence, there's different ways to try and make an estimate of the prevalence within the community. Clearly, we're interested in high-risk groups, such as people who inject drugs, men who have sex with men, and commercial sex workers. But in terms of looking at the community prevalence, often surrogate groups that are quite easy to access, such as antenatal, pregnant women, blood donors, and occupational groups are often used as surrogates for the community prevalence. But in this study, we aim to get an assessment of the community prevalence within the general population. It's also important to look at the prevalence within in patients with disease to get an assessment of the impact of the virus within patients who've got established liver disease. But today I'm going to report the findings from our community prevalence survey. So the aim of this study is to describe the community seroprevalence for hepatitis C in Blantyre and to look at the molecular epidemiology of hepatitis C within the southern region. So this is a map of Malawi. We're in the southeast of Africa. I'm sure many of you know Malawi well. Zambia to the west and surrounded by Mozambique and Tanzania. And if we look at the southern region of Malawi, there's Blantyre in the center and Blantyre city. There in the northeast corner of Blantyre is Durande, which is a large township, quite densely populated. And this is a picture from the hill overlooking Blantyre showing what the township looks like. So as part of a study looking at typhoid seroepidemiology, a census was conducted of the township, revealing around 100,000 individuals residing there. This was followed by a serologic survey using a single stage random probability sampling from the census list. We then tested among individuals in the sero survey for hepatitis C using a combined antigen and antibody laboratory ELISA. The advantage of adding the fourth generation antigen test is it improves detection of individuals recently infected relative to antibody testing alone. And we confirmed those who were positive by ELISA using HCV RNA PCR using the gene expert. The molecular epidemiological aspect of this study was to test those that were viremic for hepatitis C from the serosurvey and also in patients with cirrhosis or HCC who had been prospectively recruited from the Queen Elizabeth Central Hospital, which is a tertiary referral hospital for the southern region of Malawi. So sequencing was conducted in Glasgow, the University of Glasgow Centre for Virus Research. We used capture target enrichment with bioethylated probes and sequence using a next generation sequencing platform from Illumina and aligned reads to subtype specific reference sequences using a bioinformatic pipeline from Glasgow. So in total from the census population of 100,000 individuals, we sampled 1,661 aged over 16 years. And the median age of the sample was 30 years and 52% female. And this just shows the relationship between the census population in green and orange and the sero survey population in the lighter colors of blue and pink. And it shows that there's a close match between the population distribution of the census and the sero survey. So our accrued prevalence among the individuals was 13, which is 0.8%, which is the same in men and women. Population standardized prevalence was not different because it closely matched the census distribution. So the overall estimate was 0.8% by antigen antibody testing. And when we looked at confirmed HCV RNA positive patients, the prevalence in the community was 0.2%. So quite a low prevalence with 95% confidence between 0.02 and 0.4. Now, if we look at those who are positive, the 13 patients along the x-axis who were positive by antigen antibody testing, and we can see the 3 individuals, they were all tested in duplicate or triplicate, and you can see the 3 individuals that were HCV RNA positive had a much higher sample to cutoff ratio in the ELISA test, indicating that potentially the S to CO could be increased, as other authors have previously described, because most of the low-level positives were negative by RNA PCR. Now, if we look at the molecular epidemiology, this is the results of the sequencing of the hepatitis C samples. We can see that among the community samples, one was 4 subgenotypes as 4R, and the other 2 is 4V. And a similar picture among the inpatient samples, 4R, 4V, 4W, predominating. All of our samples were genotype 4, and it's interesting to see endemic 4R in Malawi. This has not been previously described. This has previously been identified, particularly in East and Central Africa, and in previous data from Rwanda, 4R was associated with treatment failure when using sofosbuvir, ladipasvir. So overall, to conclude, this was the first representative general population survey that we were able to identify in the published literature in Southern Africa. There was a very low rate of HCV in terms of confirmed viremic infections at 0.2%, and that compares to slightly higher estimates from modeling data based on predominantly surrogate samples of around 1%. There was a high rate of false positives when we talk in terms of confirming antigen antibody tests with PCR, showing an overall low specificity of the ELISA antibody antigen tests, and perhaps the role of using the sample to cutoff to identify those that are more likely to be true positives. And finally, we found that the genotype circulating in Malawi is genotype 4, and that there was a suggestion of endemic 4R, which has previously been found in other samples to have low rates of SVR when using sofosbuvir ladipasvir. So I'd like to thank you very much, and I'd like to acknowledge my many colleagues who've collaborated with me on this project.
Our next speaker will be Dr. Jamila Soli from Burkina Faso, presenting on chronic hepatitis C, efficacy and tolerance of direct acting antivirals at University Hospital Center.
Good morning or afternoon, everyone. I'm Jamila Abdurrahman Soli. I'm a hepatogastroenterologist, and I would like to thank the organizing committee of this conference for giving me this opportunity to share our experience in the management of hepatitis C in Burkina Faso. Hepatitis C is a viral pandemic that affects 71 million chronic carriers worldwide. This infection is responsible in the long run for heavy mortality and morbidity through cirrhosis and liver cancer. In Burkina Faso, seroprevalence is estimated at between 3 and 5% of the population. HCV genotype 2 is predominant. Direct-acting antiviral drugs have been available in this country since 2016, and our objective is to evaluate their effectiveness and tolerance in real life in our context. To do this, we conducted a prospective observational study from March 2016 to December 2019, in which we included patients who were viremic for hepatitis C virus and who had been treated with direct-acting antiviral drugs. Cure were defined by the undetected viremic load at least 12 weeks after the end of the treatment, and second-line treatment was secondarily offered to patients who failed the initial treatment. So we worked with a total number of 76 patients with the following characteristics. We had a sex ratio of 1.8%. 64% of our patients were men. The median age was 50 years. 30% of our patients had been previously treated with Guinea interferon and ribavirin. 13% of our patients were cirrhotic. The average pre-therapy viral load was 6.6 log. 74% of patients were infected with genotype 2 HCV. The other genotypes listed in the series were 1, 4, and 5. Cytolysis was found in almost half of the cases. 4 main therapeutic protocols were used in the first line of treatment. Sofosbuvir ribavirin was used for 56% of patients. Sofosbuvir velpatasvir in 17% of patients. Sofosbuvir ledipasvir in 14% of patients. Sofosbuvir declartasvir in 12% of patients. The choice of these different protocols was dictated by the therapeutic recommendations of the moment, but also by the availability and cost of the drugs. For all these therapeutic protocols, ribavirin was used in 62% of patients, and the duration of treatment was 12 weeks in almost 9 out of 10 patients. The effectiveness of the first line of treatment was documented for 71 patients. 5 patients were lost in the follow-up. As a result, we got 61 cures. This gives us an efficiency of almost 86%. Initial treatment of 10 patients failed, and out of these 10 patients, 4 were in a stage of cirrhosis, and 6 had been treated with sofosbuvir ribavirin. Factors influencing the efficiency of the treatment were investigated, and cirrhosis was significantly associated with a poor therapeutic response. We had a 90% cure rate in the absence of cirrhosis compared to 56% in cirrhotic patients. The second-line treatment was carried out in 8 out of the 10 patients who initially failed. It was based on the sofosbuvir velpatasvir protocol with or without addition of ribavirin, sofosbuvir velpatasvir, and the cure of those 8 patients resulted in a cumulative efficiency of 97.2%. From the viewpoint of the treatment tolerance, 58% of patients reported no side effects. The most frequently reported side effects were headaches in 21% of patients, asthenia in 18% of patients, and non-specific digestive disorders in 13% of patients. We also noted the occurrence of 1 case of anemia and 1 case of reactivation of hepatitis B virus in 8 co-infected patients. What comments can we make on these different results? We got an 86% efficiency rate, which is comparable to that reported by ACHA in Cote d'Ivoire, but which remains modest for direct-acting antiviral drugs treatment. This modest tone, as well as the negative influence of cirrhosis, can be explained by the majority used in our series of sofosbuvir ribavirin protocol. This protocol has indeed a suboptimal efficiency and is moreover influenced by the stage of fibrosis. Some authors also reported poorer cure rates in real life than in clinical trials. Finally, we can also evoke the involvement of genetic factors or the physiological state of patients. A large American series involving more than 15,000 veterans reported poor therapeutic efficiency in African American patients. In a French center, Dijon reports a less efficiency in the subject from sub-Saharan Africa. At the end of this presentation, we remind you that direct-acting antiviral drugs are a major revolution which allows us to offer a therapeutic option to all patients infected by hepatitis C virus, whatever their comorbidity and the stage of cirrhosis. They have an excellent efficiency, close to 100%, and an excellent safety profile with simplified regimens. Such regimens, sofosbuvir velpatasvir, has been available in Burkina Faso since 2017. Currently, the challenge lies in the generalization of screening as well as the accessibility of assessment and medication. Efforts must be made towards this goal if resource-limited countries such as Burkina Faso are to reach the goal of eliminating hepatitis C infection by 2030. Thank you.
Our next speaker is Dr. Tari Michael from Egypt, presenting on prevalence of occult hepatitis C virus infection among Egyptian hemodialysis patients, a single center study.
So our presentation today is about the study we did about the occult hepatitis C infection in patients with on hemodialysis. I would like to thank Professor Dr. Noha Naqib, Professor Dr. Mu'taz Said, and Dr. Amira Al-Araishi for their effort to complete this work. We declare no conflict of interest in the study and the approval of Ain Shams University Ethical Committee for the study. The contents of our talk today are going to be the introduction and aim of our study, the methodology, the results of our study, and the conclusion. So, occult hepatitis C is the presence of hepatitis C virus RNA in the liver tissue and/or peripheral blood mononuclear cells with undetectable hepatitis C RNA in the antibody or antibodies in the serum. This was described by Castillo et al. In 2005, where he found hepatitis C virus replicating in peripheral blood mononuclear cells. In the liver biopsies, patients with chronic hepatitis C had frequently more necroinflammation, more fibrosis than occult hepatitis C patients, but liver cirrhosis was diagnosed in a similar frequency in both groups. This was a study done by Pardo et al. In 2007. It is well known that hemodialysis patients have an increased risk of infection for chronic hepatitis C due to nosocomial infection, vascular access, and to the recurrent blood transfusion. So in our study, we aim to evaluate the prevalence of occult hepatitis C among patients on maintenance hemodialysis. Our secondary aim was to study the predictors of occult C in hemodialysis patients, where clinical laboratory parameters were studied in occult hepatitis C patients and other patients with end-stage renal disease. The patients and methods of our study: 60 end-stage renal disease patients on hemodialysis were studied with negative hepatitis C virus RNA and negative hepatitis C antibody by ELISA. Patients with confirmed hepatitis B and C or C were excluded from the study. And we did a study for the PCR of the hepatitis C RNA in the peripheral blood mononuclear cells of those patients. And then the patients subsequently were divided into two groups, occult C positive and negative groups, where clinical imaging and laboratory parameters were studied in both groups. The results of our study was that patients with average age of 48 and male to female ratio of 11:9 were the population of our study. 6.7% of them had history of blood transfusion. The main cause of end-stage renal disease was mainly hypertension in 50% of the patients, diabetes in 20% of the patient, and less common causes like polycystic kidney disease, recurrent urinary tract infections were also present. The prevalence of occult hepatitis C was 11.7%, which is 7 patients of the 60 patients studied. In comparing the clinical and ultrasound findings in both occult C positive and negative cases, we found that ascites, lower limb edema, and jaundice were both clinically prevalent, more common, and significantly in patients with occult hepatitis C than patients with occult C negative patients. So on applying the logistic regression analysis, we found that bilirubin, total and direct bilirubin, were predictors for the presence of occult C in hemodialysis patients. And by putting that on our curve, we found that a cutoff value of 1.7 for total bilirubin and 0.4 for direct bilirubin were the cutoff values to predict the occult C in hemodialysis patients. So in our conclusion, we believe that hemodialysis patients are liable for occult hepatitis C infection with a considerable impact on their health. Total and direct bilirubin are predictors of the presence of occult C with cutoff values of 1.7 and 0.4 milligram per deciliter respectively. So thank you. That's the end of my discussion.
I would like to thank all the speakers for their excellent presentations and presenting very interesting studies. I would like to remind the delegates that they can meet the abstract presenters from the last 2 sessions and ask them all the burning questions. To do this, please go back to the timeline and choose the abstract presenter you would like to talk to in the Meet the Oral Abstract Presenter session. They will be happy to answer your questions. We look forward to seeing you again tomorrow for more interesting presentations and discussions. Thank you.